Good morning and good afternoon. It's a great pleasure for me to welcome all of you to this conversation, these fantastic presentations on uh, justice, equity, inclusion, and improving perinatal outcomes. My name is Tamil Kendall, and I'm the director of the Partnership for Women's Health Research Canada, which is an alliance between the Women's Health Research Institute in BC, the Women and Children's Research Institute in Alberta, Women's College Hospital in Ontario, and IWK Health located in Halifax with a mandate to serve the Maritimes. And we have come together in the firm belief and with the mission to advance the health of all women, trans, and non-binary people through better research. And for us, better research is research that is rigorous because of its inclusivity and really taking into account all of the populations that need to be taken into account. And we're supported in this mission and vision by our sister alliance, the Women's Health Collective Canada, which brings together the foundations that support the research institutes and the hospitals. So before we get into the meat of the presentations, I'd like to take this opportunity to recognize and really express my gratitude for the lands that I live in. I am located on the traditional territories of the Lekwungen-speaking peoples in what is colonially known as Victoria, British Columbia. And so I live on the territories of the Esquimalt and the Songhees First Nations, and in the lands where the Saanich people have historical roots that continue up to today. So I really express my gratitude as an uninvited settler on these lands to be here. And I'd like to provide an opportunity for all of you, because we're joining from across Turtle Island and beyond, to take a moment to really think about the lands, the peoples, and the territories that you're on today. So our first presentation today will be by Dr. Modupe Tunde Bias and Dr. Isabel Malame, and they're focusing on knowledge mobilization to address pregnancy-related near-miss events and deaths in Canada. So brief introductions of them both. Modupe is an associate professor of obstetrics and gynecology at the University of Toronto. She's co-founder of Women Health Education Made Simple, WEMS, and her interests include, but are not limited to, pregnancy complications and quality improvement and patient safety, like decreasing cesarean section rates by increasing access to trial of labor after cesarean section, an intervention very close to my own heart. Dr. Isabel Malame is a clinician scientist specialized in obstetric medicine and an assistant professor in the Department of Medicine at the McGill University Health Centre in Montreal. She's the principal investigator of the Laboratory for Pregnancy and Postpartum Health Improvement, known as LOUV, and her research program is supported by CIHR, and it aims to generate and mobilize knowledge to reduce pregnancy-related serious complications. So with that brief introduction, I will hand it over to you, Modupe, and I would ask everyone in the audience to put questions into the chat. Thanks very much.
Thank you so much, Tamir. Can everyone hear me? Okay. So thank you so much for that nice introduction. And I just want to take you through my speaker's disclosure. And also, I'm an OB provider. I also identify as a Black woman. I'm also the past president of Black Physicians of Canada and the president-elect of Federation of Medical Women Council. So my talk today might be woven around inequitable care in women and also intersection with race. For this presentation, when I say women, I mean women plus those who identify as such, including cisgender, trans, non-binary, two-spirit, and feminine identifying people. Thank you so much. I am calling from Ontario in the traditional territories of the Wendat, the Haudenosaunee, and Anishinaabe people, whose presence here continues to this day. I'd like to acknowledge that this is the treaty lands of the Mississaugas of the Credit, and I thank them and other Indigenous peoples for sharing this land with us. As a Black person, I also share the Black history ancestry, a deep and profoundly relevant history of Black peoples in the diaspora, a history, lineage, and inheritance that predates this country, chattel slavery, and colonialism that begins with Africa. An ancestry that recognizes the struggle and survival while honoring our narrative of pursuing self-determination. So today, I stand valued, grateful, and proud to be Black. These are my goals and objectives, and I'll try to cover most of them. But as Isabel is going to be speaking, you would understand the reason why my goals and objective actually mirrors the partnership and community engagement that the hub tries to create. So as Black people in Canada, it's important to understand the demography that Black people collectively represent 1.5 million of the Canadian population, and 16% of the population of Canada are racialized. Amongst the Canadian Black population, majority now are born from sub-Saharan Africa, and about 35% are born in the Caribbean and around the Bermuda. And it's important to understand these demographics because you can understand when we say women with pre-existing conditions. Most of these people live in Toronto, okay? And by 2041, the Statistics Canada predicts that the Black population would have doubled by that time. Social determinants of health, as you are aware of, are the key, some of the things that we talk about in education, employment, housing, policing, the justice system, and for today's talk, healthcare. And we know that anti-Black racism and systemic discrimination are important drivers of the inequities that we see under these categories. And facts about Black women: they experience poor health outcomes and increased maternal mortality and morbidity. And we can see those in different facets. For example, high blood pressure, gestational diabetes, or pre-existing diabetes, asthma, connective tissue diseases, pre-pregnancy overweight, high increase in cesarean section. So by and large, we are seeing all this increased perinatal mortality and morbidity accentuated in Black women. And looking at this graph, you would appreciate that almost everything it's increased in Black women. And when you look at this nice data here, except for things like congenital anomalies and major perinatal laceration, every maternal outcome and poor obstetrical outcome is accentuated in Black women, including things like preterm birth, hypertensive disorders, diabetes, obesity. The study that was done shows that women who are overweight and obese, there's significant increase in hypertension, preeclampsia, diabetes, and of course, operative vaginal delivery from fetal macrosomia. Then the second study was done by Carlene Wilson, a retired midwife, who showed the perinatal outcome of uninsured immigrants and refugees. 40% of them came from Caribbeans. 56% received no prenatal or inadequate care. And there was increased cesarean section due to abnormal fetal heart rates. and of course, increased neonatal resuscitation. A study that was also done by Joe Ray, looking at the rates of eclampsia and preterm birth. When you look at Canadian-born mothers, the rate is 4 per 1,000, but this rate is significantly higher in women emigrating from sub-Saharan Africa, notably Ghana and Nigeria, those coming from the Caribbean, and also from women emigrating from Colombia. And of course, we see that the preterm birth is significantly high in indigenous population as well. Looking at the graph on your left-hand side shows that we're doing well in terms of maternal mortality in everybody in Canada. But it's also important that we focus on severe maternal morbidity. And severe maternal morbidity in the Canadian context, the rate is similar. If you're an immigrant or if you're born in Canada, except if you are born in places that are outside of Western or European countries, where the rate is about 9 per 1,000. But when you're born in sub-Saharan Africa, the rate is 23 per 1,000, and similar to if you were born in the Caribbean. So let's talk about the disparities. We all know about the disparities in maternal mortality generally in Black women. And this mortality rate has increased from 2018 to 2021. The data I am showing is from United States of America, where in 2021, maternal mortality rate in Black women is 70 per 100,000 compared to their white counterpart, which is almost 27 per 100,000. The rate is similar in the UK, whereby maternal mortality in Black pregnant population, it's at least 4 times their white counterpart. In Canada, we may not have the robust data, but we do have something that we can work on. It may not be the best data possible. This is the mortality that was looked at in the last 20 years in Ontario. Needless to say, most of the mortality that we're seeing in the 5th quartile, and these are areas where there are immigrants, mostly Black population. But when you look at the data from the racial data, they were able to analyze 133 out of the 215 deaths that were of racial origin, even though there was missingness of the data. 63.8% identified as white, 28.2% as Asian, and 7.2% as Black women. And when you look at the deaths, there were overrepresentation within the Black population. For early deaths, it was 18.3%, and for late deaths, 12.3%. So our data may not be robust, but it's still mirroring what we see in other high-income countries. Similarly, the rate of preterm birth is also higher in Black Canadians compared to their white counterpart. And we can show that this mirrors what we see in United States, where the disparity is also similar. What do we need to do? Black women are turning to Black midwives, Black providers, doulas, to decrease the poor perinatal outcomes that they're facing. And studies have shown in United States that birth centers that look at culturally focused care for women of color have shown to have better outcome in Black women. So what do we need to do? We need to, of course, modify obstetrical outcomes by looking at healthcare behavior, smoking, even food insecurity. It's important in the Black population. How do we also modify our policies and focus on QI projects? We don't have to wait for race-based data. What we have now, we can still work on those parameters. We can create guidelines and look at benchmarks that perhaps we should be changing the way we collect race-based data using the benchmark that looks at the Black population. Also, looking at how do we change the way we look after immigrants when we know they're coming from sub-Saharan Africa. They may be coming with pre-existing conditions like cardiac, renal, sickle cell disease. So we can walk around these women, start low dose aspirin as soon as they come into care. And for women who come into care late, we need to be more mindful of how they are looked after. Community involvement, of course, is important, and also other things about collection of race-based data. Education of providers, I can talk more about that, because if we understand where these populations are coming from, we are able to plan ahead. Co-creation with different organizations and engaging the immigrant population will be very important. Inclusive research that would address the social determinants of health will go a long way. Of course, trust. We know trust within the Black population is very, very important because of the historical marginalization that they have faced during research. Especially the popular one is the United States Public Health syphilis studies, where a lot of Black population were harmed during this. Same as COVID-19, and it wasn't surprising that the Black population did not want to get the COVID-19 population, the vaccine, because of the historical mistrust that has happened in the past. So when we are looking at research, we need early engagement, which is what the GM Hub is about. Co-creating with the Black population, not a last-minute research, but to start with research methodology, avoid tokenism, address things that will foster collaboration, and also thinking about, invariably, our aim is to improve health and wellness of the pregnant population. So co-creating knowledge mobilization activities will provide a safe space for everyone to meet and to thrive. It will be an area where we can focus on key mobilization strategies and also involve lived experience researchers, knowledge users, so we can all sit together with the ultimate goal of reducing the existing health inequities. So there are so many call to action, focusing on collaboration, education of both the healthcare providers and the patients that we treat, and also recognition of what the achievements of the Black population has been, even in those inequity research that has used pregnant Black women. For example, we will talk about Dr. Sims, and also the obstetrical multiple surgeries that he has performed. Black women need to be recognized for their contribution. How about scholarship and research? Black research only accounts for less than 1% of the research dollars. How do we improve that? Inclusive excellence, I talked about, caring for patients and also within their community. And of course, the policy and advocacy for a change in policy that would change the way we look at research and also the way we care for women generally. I also want to let you know that when we work together, we can always achieve better things in the future. Thank you so much for giving me the opportunity to speak. I will hand over to my co-presenter, Isabel. Thank you.
Thank you so much, Modupe, for this presentation and for setting the stage for what I'm about to talk about, which is the work that we're conducting in our hub, which is called the GEM Hub. And GEM stands for Knowledge Mobilization for Pregnancy and Post-Pregnancy Care. And GEM is also meaningful to us because it really symbolizes the unicity, the specificity of each pregnancy experience, the resilience that can take place sometimes when faced with hardship, and just the beauty of pregnancy and post-pregnancy. So I will start with our land acknowledgement. I do acknowledge that the land where I live and conduct my work, Tiohtià:ke, is located on the traditional and unceded territory of the Kanien'kehá:ka, which is a place that has long served as a site of meeting and exchange among indigenous peoples and other peoples, and that continues to carry this tradition of cultural mixity forward. It is important for us at the GEM Hub to do this land acknowledgement because we want to recognize, acknowledge, think, and address the colonial structures in which we conduct our work. And on a personal note, as a second-generation immigrant settler, the ability to be on this land is not one that I take for granted, and I'm deeply grateful to the stewards of the land. Now, today I'll be presenting about our work that is conducted within our hub, but the hub is part of a larger coalition, which is called the National Women's Health Research Initiative and the Pan-Canadian Women's Health Coalition. And the particular topic that our hub wishes to address is pregnancy-related near-miss events and deaths. And we're doing this work among a large group of people within a tripartite leadership that includes Dr. Rohan D'Souza, who's a maternal fetal medicine physician and scientist who works in Hamilton and Ontario, and Robert Finch, who's representing the Canadian Perinatal Programs Coalition, which is a group of provincial organizations that look for quality improvement studies, quality improvement initiatives in the perinatal health field. And our hub really aims to be a network and a space to co-create together person and community-centered knowledge mobilization activities to address the central issue of pregnancy-related complications and ultimately to improve the health and wellness of women and gender diverse people in Canada. There are multiple people on the hub, including over 70 individuals that either are from or work closely with key and often underrepresented groups across Canada, including racialized, gender diverse, and Indigenous persons. And it's an interdisciplinary group. Yes, we come from areas of medicine, midwifery, obstetrics, but also public health, epidemiology, community health, and of course, lived expertise as persons with lived experience of pregnancy and their support people. When we say that we do knowledge mobilization, what do we mean exactly? Knowledge mobilization is a big, large, non-specific umbrella term that really refers to the interrelationship between the production of knowledge and the use of knowledge, and it encompasses activities related to knowledge synthesis, dissemination, transfer, exchange. So it really lives in that place between the production and the use of knowledge. And what we mean by co-creation is when we refer to this creative, collaborative, collective process of actively engaging to shape an innovation or a creative process. Co-creation can only be achieved through respectful interactions and dialogue, so a back and forth and exchange where everyone's voice is considered. And when we engage in co-creation work, researchers accept a shift in traditional power dynamics from being fully in charge of decision-making towards being equal partners with every member of the team, including persons with lived experience of pregnancy. So co-creation is a form of knowledge mobilization that really partners with everyone involved. So how do we use knowledge mobilization in the hub? Well, our aim is really to stop perpetuating systems of oppression and marginalization that are faced by women and gender diverse people in healthcare. And so the knowledge mobilization activities are really a space where we will be co-creating along with persons and communities that do carry the greatest burden of harm. And when we talk about severe maternal morbidity, which we recognize is not an inclusive term, this is really the term in the literature that refers to a set of unexpected outcomes that are related to pregnancy, labor, childbirth, and the post-pregnancy period that may result in severe illness, prolonged hospitalization, or long-term disability. So mortality is really the tip of the iceberg, but for every maternal death, there are way more severe maternal morbidity events that occur. In fact, 85 to 100 more severe morbidity events. So for this reason and other reasons, the World Health Organization has recommended a focus on serious maternal complications such as severe maternal morbidity to monitor and improve the quality of pregnancy care. And in Canada, as you heard earlier, the incidence of these types of complications is rising. And because there is a disproportionate burden that has been carried by racialized, immigrant, Indigenous, as well as sex and gender minoritized populations and persons with other instances of marginalization, we really need to reduce the knowledge to action gap in partnership and through knowledge mobilization activities. At our hub, the knowledge mobilization activities are going to be centering around the theme of pregnancy-related near-miss events and death, and the process that we will use to carry out these knowledge mobilization activities will really be centering on a research justice framework. So a research justice framework seeks to incorporate and involve multiple sectors and the input of multiple people with different types of knowledge that are all considered valid and important in the creation process. So we are looking to incorporate people with experiential knowledge of pregnancy and or pregnancy complications, mainstream or academic knowledge. So that's the traditional university researcher type of knowledge, as well as cultural or spiritual knowledge, harnessing on the wisdom of the communities that we're all a part of. So to really have all these different forms of knowledge interact together to co-create the knowledge mobilization activities. On our menu for the hub, we have 5 knowledge mobilization activity types. First, it's a priority setting activity because ultimately we want to be able to create knowledge that is aligned with community-centered priorities. So we're now starting this process of understanding what are the different priorities that people have in mind to address pregnancy-related near-miss events and deaths. We're also looking to develop educational material to construct culturally appropriate and gender sensitive support resources to review near miss events when they occur in hospital settings or other settings, so that clinical teams can look at what has happened in order to improve the care going forward, and doing so in a supportive way and in a way that is holistic. We also want to create a knowledge repository that incorporates both Western ways of knowing and Indigenous ways of knowing, with accessible information on solutions to prevent near-miss events and deaths. We want to create process maps, which are human-centered processes to incorporate new clinical practice into clinical care. And this is a project that is coming to term now, that we've completed over the past year, really to build a roadmap for the different teams whenever they want to incorporate a new evidence-based practice, and to do so in a way that is centering on people across all levels of the systems that we work in, and an ongoing process of public outreach via our outreach town halls. And these town halls occur twice a year, and you're welcome to join them at any point, where we give updates on our progress, seek feedback, insights on what we're doing, and really keep a public accountability for the work that we're conducting. Throughout this process, we're looking to engage with persons and families with lived experience of pregnancy, including, but not exclusive to, near-miss events, community partners, healthcare professionals, and other knowledge users, decision makers, policymakers, and researchers. Because we're a large group of people that comes from different horizons, it is really important for us to have a process to engage together, because we think that the process of creation, as in all participatory types of research, is as valued as the actual results and outputs that are created. So to do that, we've developed expectations of how we will be working together in the different spaces of the hub. There's our process is centered around our organogram, so how we're organized within the hub, our terms of reference for the advisory sharing circle that really is at the heart of our hub, and the group norms or the guidelines for working together. And all these together form our governance structure, which we've spent the past year working on. So this is how our hub is organized. As I mentioned, we're centered around an advisory sharing circle that aims to incorporate the perspectives of people with mainstream or academic knowledge, experiential knowledge, as well as cultural and spiritual knowledge. The different knowledge mobilization activities are carried out within working groups that do, again, involve this multi-sector input. And throughout the process, we are interacting with the different groups that compose the hub community. So persons with lived experience, community partners, knowledge users, decision makers, researchers, and accountability to the public via our town halls. Our terms of reference that really shape how we work within the advisory sharing circle have been co-developed and informed with an interim steering committee and persons with lived experience of pregnancy. To do that, we used conversation prompts by asking strategic questions for how to co-build these terms of reference together. Examples of such conversation prompts include, if you've been involved in a group like this, what did you find created success? Or how should decisions be made in meetings, including consensus-based versus other strategies for reaching decisions? And we drafted our terms of reference, which was iteratively revised. So the terms of reference really apply to our advisory sharing circle. Now, the group norms, which apply to the larger hub community, adhere to the Valuing All Voices framework, which is an existing framework that has already been created and that is really meant for teams that are research teams or other groups that are looking to employ trauma-informed approaches, intersectional analysis, and critical reflexive praxis in the co-development of meaningful, inclusive, and safe engagement strategies. So really describing what we aim to do and strive to do within the hub. And those values are education and communication, understanding and acceptance, trust, relationship building, and self-awareness. But now, as you can see, all these values are currently sitting in the clouds, in the sky, and we really wanted to turn them into actionable items. And so to do this, we transformed our hub launch into a workshop in March 2024, where we asked reflexive questions in breakout rooms with all of our hub members who were attendees, asking them to give us examples of how we could enact these values. So for example, for trust, what are some actions that we can take to foster an environment of trust in the hub? Or for understanding and acceptance, can you reflect on a community that you are a part of where you feel understood and accepted? And what are some factors that led to that feeling? So really, in order to take these values and bring them to life, we took meeting notes from our virtual whiteboard that were synthesized and that were consolidated in a guidance document for organizers and facilitators, as well as hub members. And this document has been finalized, has been reviewed by all hub members and approved on and consented on. And essentially, we now are listing the different things to think about or group norms that we want to incorporate in all the spaces of the hub. So to give you an example for the value of trust, when organizing gatherings or after gatherings, hub members are invited to offer one-on-one contact prior to group meetings to enhance trust, to ensure different forms of engagement options and transparency, and to prepare the space for hub members and intentionally offer various kinds of support. So this is just an example of how we can foster trust within the hub from the perspective of organizers and facilitators, but from the perspective of attendees, we want to be able to value various forms of knowledge in others and within ourselves. We want to offer feedback to hub team and any additional information or resources that are related to severe morbidity and that identify gaps in the current work of the hub. So this bilateral exchange is what will be fostering trust within our hub. So the group norms of the hub really apply to the whole of the hub. And because they've been created really in the spirit of enhancing the safety and the ability to exchange in tables that are tables where we have people coming from multiple sectors, we really think that these could be used across other hubs or other research groups to foster an environment building on the Valuing All Voices framework. So I've presented some of our hub journey, and it looks quite linear in different phases, but in fact, it really was not linear, and phases often were ongoing at the same time or overlapping, and were not the linear, continuation as what I've just presented. So we started off with the input from the multiple groups that really shaped the hub proposal back in 2021, 2022, and the funding that we secured. Then we developed our interim steering committee for the development of the hub's governance structure, and we met with persons with lived experience of pregnancy to further develop the hub's governance structure. And we finally launched, had our first advisory sharing circle meeting, and I think we're now preparing our fourth advisory sharing circle meeting, or fifth, and conducting our knowledge mobilization activities. So all this work to date to be able to do our working groups and do the knowledge mobilization activities, but developing this structure and this process was really essential to ensure that our process was equitable and safer for people involved. Reflecting on challenges that we've encountered to date, of course, this is a sensitive topic, it's sensitive areas, and we always need to advance with this in mind. And when we are engaging in profoundly co-creative work and starting off processes from scratch and co-creating from scratch, it comes with an inherent lack of clarity at the beginning because we're collectively building things. So we're not coming with structures that are already prepared and ready to go. So sometimes there's a lack of clarity, and especially when onboarding new members, it's really important to bring them up to speed and for them to understand the context in which we work. And as you can see, different hub members and people involved in the different structures of the hub didn't all join at the same time. So this is something that we learned as we went. The work must progress slowly because we're moving as a large collective and we're using participatory methodologies. So we cannot go from point A to point B in a straightforward fashion. And this is the beauty of the process. We're going together and making sure everyone is on board as we move forward. And there are some budgetary and time constraints. Our funding is really funding within a finite period of time. We would love to meet in person when we're having our advisory sharing circles, but we can't. Our budgetary constraints are too strict. So we're navigating these and using the tools that we have to still bring humanity and a sense of community despite these constraints. So with that, I really would like to thank everybody who is part of the hub or working with the hub, especially our tripartite leadership members. And you'll hear from other hub and hub leaders who are presenting today, who are really essential members of our hub and really mentors. And I'm thinking about Modupe and I'm thinking about Saraswati, who are here, who we really could not have been doing this work without them. And I really would like to thank the hub team, our wonderful project managers, Donnelly McIntyre and Kate Mazzetti, who are probably here in the audience and who really bring to life all the different spaces of the hub and are connectors with the communities, the members, and people of the public who are interested in the hub. So thank you once again to this beautiful team, and I remain available for any questions.
Thank you very much, Modupe and Isabel, for that very interesting presentation and pointing out some of the challenges of doing this co-created work, but also the richness in doing so. I'll ask everyone to put the Q&A function is now working. So if you have comments and questions, please use the Q&A. We're going to turn now to the next panelists, Mary Ann Forbes and Dr. Patty Johnson, who are going to present on the Inuit Perinatal Health Hub, building Inuit-specific resources and support for Inuit women in the Kavalik region of Nunavut. And I'll give a brief introduction of both of the speakers. Mary Ann Forbes is proud Inuk, born and raised in Nunavut and the Northwest Territories. She's advocated for children, youth, and vulnerable adults in nonprofit education, government, post-secondary, and public sector settings, while also encouraging organizations to decolonize and incorporate Indigenous ways of knowing, being, and doing. Marianne expresses that she's grateful to be part of the Inuit Perinatal Health Hub project and to build resources and capacity in community with other Inuit. Dr. Patty Johnston is an assistant professor at the University of Calgary in the Faculty of Social Work. She is Kwalunat, non-Inuit, a non-Indigenous scholar that has worked with Inuit youth, women, and families in Arctic Canada for over 2 decades. Having lived in the Arctic and worked with government and health social services organization, she holds an awareness for the range of challenges and structural issues facing remote communities, as well as the processes, policies, and practices that serve to reinforce them. So welcome to both Marianne and to Patty. Please go ahead. The floor is yours.
Thank you so much for the introduction, Tamil. And I'm so glad to see, I'm honored to be here with my partner, my colleague, Marianne, and we're going to be a little bit more informal today as we pass things back and forth to each other, and I hope that's suitable to everyone. But I thought we would start just, and first of all, really mention that we're honored to work on and live on Indigenous territories of Treaty 6 and Treaty 7, where we both have offices in Edmonton and in Calgary, and home to the Métis Nation of Alberta and many nations. We're also grateful that our work largely occurs in Nunavut, where we get to live and work and share on, the traditional and the existing territories of Inuit throughout Inuit Nunavut. And most of the work that we're talking about today largely is centered in the Kivalliq region, which is the 7 communities north of Winnipeg. And we will tell you a little bit about that. So we did our presentation a little bit different today in the sense that we thought we would share images and talk a little bit about, kind of how we came to the work and where this work is taking us, and also offer you some information that we think is relevant to what we think that might be important to all of you listening, and but also to health and social services workers across Canada that could be utilized both as researchers, to share through knowledge translation approaches and practices. But a little bit about how we came to this work is back in pre-pandemic, and we got a little bit of funding to go initially through a CHR grant to go to participate in an Indigenous Gender and Wellness conference in Montreal that was being put on by CIHR, and myself and and a colleague from Nunavut that I had worked with for a long time went, and we got a little bit of funding to start talking with women in RV at Nunavut about their most concerning and pressing healthcare issues. And over and over and over again, it came up around prenatal, perinatal care, over and over. And while the additional research funding we got at that point was to really kind of start to support and bolster existing programming that was existing in Nunavut, in Arviat, and that's where you see this picture here of Anana's Arviat. That really grew and grew when women referred to, again, the desire for perinatal resources. And initially, we kind of said, oh, sure, perinatal resources, but it took us some time to really realize that that was a massive undertaking in itself to really start to understand what that meant exactly and how that meant, and led to the development of the Inuit Perinatal Health Hub, which really got underway with an initial workshop with some Inuit knowledge holders in Montreal, where discussions around what really constituted Inuit perinatality and understandings around Inuit perinatality and how different and separate and important they were to both Inuit culture but Inuit wellness, but were really located in understandings that aren't necessarily the same as within the dominant culture. And what you're looking at here on your right-hand side is a wall hanging developed by Lydia, and this wall hanging really represents and highlights a number of the different, and I refer to them as kind of entry points or ways into conversations around Inuit perinatality, that really kind of signal a bit of a map or frame. We're, at the moment I'm using dominant culture words, but a framework or a map for starting to understand how Inuit perinatality kind of, the approach, the understandings, the importance, the ways of knowing and being that are associated with really recognizing this period of time in lives, in Inuit lives. And in dominant culture, we often refer to perinatal as kind of the period before, during, and kind of post-birth. That is really a very dominant consideration for perinatality, and this wall hanging serves to offer us additional insights around that. So much of our work going forward has all been, really all of our work going forward has been dedicated to walking consistent with this map, with this guide, with this framework that leads us forward. As part of this, we have moved to build in, working with, one thing that's really, really important to our work, and even before I get into that, is, why is this important? Why is it important to talk about this with Inuit? For those of you who aren't familiar with working with Northern life and with Nunavut and with the Arctic in general, over 80% of women in the Kivalliq region are required to leave their communities to go give birth in Winnipeg and dominant culture areas, where the majority of women in the Kivalliq speak Inuktitut as a primary or first language, moving to go, some of whom, and actually a number of whom are unilingual, going to travel over 1,000 kilometers to give birth, where one is required to be kept in what is referred to as confinement for up to between 4 and 8 weeks. Typically in Winnipeg can be an extremely stressful time, and we've got quite a bit of research around all of that. The thing that a lot of people don't know is that a lot of these women are very young. And in fact, over 40% of the population of Nunavut between those giving birth are between 15 and 19 years old. And not only are many of these people young, they also, these individuals giving birth, and I'm cautious to, we want to be inclusive of all genders, but in the North, typically referred to as women, those women giving birth are not only young, they're also experiencing some of the highest rates of different factors that contribute to preterm births. And as a result, Inuit women have one of the highest rates of preterm birth in the world, or very, very high, up in the top percentages. And because, one thing that is often, and we know about in the literature, we know about all the things that contribute to preterm births, but not only is there significant social stresses on individuals during pregnancy at this time, we also see that there's a great deal of cultural stressors that are potentially contributing to high term births. And this is something that the Hub is really trying to look into a little bit more seriously. But some of the things that we're also concerned about is all the different social determinants of health that also play into these that are also the same conditions and fall in line with these same conditions of potentially leading to and contributing to preterm births. So this population is, and that includes things like food insecurity, housing insecurity, violence, smoking, and many of the challenges that we're already familiar with. Some of our work then, because we're always thinking about the context within which we work, which has been filled with nonstop colonial and racist policies since the initial kind of medicalization at birthing in the North, kind of beginning in 1950s, Inuit families there's been a great kind of intergenerational divide often between young and older individuals within communities, and in large part because of these policies, but also through other policies such as, the travel and the forced kind of movement of Inuit through to medical things such as sanatoriums in the South. There's quite a number of pieces that have contributed to this intergenerational kind of gap in transmission of knowledge. So one of the important pieces of the work that we do is really ensuring that we bring and create space for Inuit elders and youth to be together, so that the sharing isn't just provided to Kalanat researchers, such as myself and but also you, Marianne, but like not to just us researchers, but to within the community. So everything that we do is really built through a process of engagement and conversation. So we do, because our work is highly community-based and highly participatory, elders and youth sit at the center of all of this. And so here you'll see that this is our Youth Arctic Coalition at a conference in Vancouver in October. And the two elders that ultimately are I refer to as the heart and the backbone, but the elders that guide our work, elders Tagak, also Mata Evangelit Palmer, and Honorable Lavinia Brown. And they have really given us our marching orders in terms of how we go forward and what we do. And but in terms of the evolution of the project, we've had to, kind of start with this idea of co-building perinatal resources that really support Inuit women in terms of what they want, what they need, what their desires are. We work from a really desire-centered framework for research. And to do that, though, we also, had to start somewhere. Before I turn it over to Mary, I'm sorry, my long-winded description. We started with we went into two communities back in March in Nunavut, and we spent considerable time working and meeting with elders in the community, sitting with women, doing interviews and focus groups, and conducted a large survey. We had a town hall meeting on a Sunday afternoon where almost 100 people came out, which highlighted like a real interest in the topic area, which is, as someone who's worked in the North a long time, we know a lot of this, but to see the drive and the connection and the real motivation to be a part of the work highlights kind of the importance of also what we're doing. So that's it's really wonderful to see. Unfortunately, the sad part of that is we heard over and over and over and over countless stories. And I'll just go back to this one slide here, which I believe kind of offers a bit of a, highlights the experiences that many of the women really have, both within the community, but also when they go south to give birth. Within the North, for the most part, most Inuit women are accessing health and social services care from Kablanat, non-Inuit women or non-Inuit staff, not necessarily women, but from staff, but also in the South. And even the term scolded here, you can see that there's an infantilizing or, ensuring that someone is understood as lesser than or reduced to. And we work from an anti-racist perspective, and we work, really in terms of anti-colonial kind of considerations for all of our work. And I think this statement really highlights the colonial relations that are in play at all times, both within the North, but also in the South. And some of the comments that we continued to hear from women were, the highest level of trauma over and over and over again. And a lack of being heard, a lack of being understood, being dismissed, being, treated rudely, being swept aside, not being treated as human, and definitely not having any of their cultural needs met in any way, shape, or form. Repeatedly, we heard comments in March around women not having consent or giving consent for the procedures that they were experiencing. And this includes not knowing what a C-section was before it was being provided, having a DNC without their consent, Depo-Provera shots being administered to women without their consent. It was upsetting is an understatement, I think, from our time, going through these really detailed experiences with women over and over and over again. And we're continuing to do the analysis at this point and work through, but a number of pieces came up around contraception and support and information. And in some ways, as a researcher, and even in terms of, what the hub can offer in terms of knowledge translation, it feels like, and I use the term low-hanging fruit, it's such basic information that women were indicating that they didn't have access to, such basic supports that they were indicating that they didn't have access to. and really, it wasn't even just because sometimes we refer to, the difference between, informed compliance and actually having a rights-based, access to care. And this wasn't even informed compliance. This was, really not informed, forced compliance without consent, and in some cases, assault on women. One of the big pieces that came out of this work, and then I'll hand it over to you, Marianne, to talk a little bit about our next steps and where we came to, was we learned a few things. One was from that time that we needed to do three key pieces. Women really wanted resources, both in person. They wanted to access in-person supports and resources, but they also wanted to be able to access supports through some form of tech option. And so we explored that a little bit deeper, and we've settled on the idea about VR headsets, like virtual reality and immersive technology headsets that could be distributed and shared within communities. And Marianne will get into this more in a moment. But also more opportunity to speak with elders. Elders raised a number of concerns, both, largely around the socioeconomic conditions within communities and the ability to care for children given those conditions. And a big part of this was also just around the social and cultural stressors and how to support women in light of those social and cultural stressors. Women repeatedly since that time have told us their fears about going north or going south for accessing care. And one of the big fears is also around child apprehension and child removal while they're in the healthcare system. And our research has shown that these are really real, really relevant fears that they possess. In Manitoba, where with the highest rates of child removal in Canada, their birth alerts were stopped in 2020 as one example, but just on the cusp of stopping those birth alerts as they were no longer publicly appealing to the public, and the government realized that this was in effect really just a systematic approach for ensuring that there was a disproportionate number of Indigenous children being apprehended and taken from their families through the hospital systems. A new policy went into place that ultimately served to do birth alerts just in reverse, in a different way. And by that, they've created a list of indicators of which Inuit women, or Inuit, particularly coming from the Kivalliq, tend to meet a number of those criteria just by arriving to give birth, such as not having access to social support because you've just traveled 1,000 kilometers to give birth, or being young, as I mentioned before, under a certain age, having challenging housing, those kind of things that are just common to living and being within the Kivalliq region in Nunavut. And so some of our our work is really around also talking about rights and sexual and reproductive rights of women, and that ability to be able to go in and give birth without fear of having your child taken from you, or to be able to seek medical care for your infant without having your child taken from you. So that and conversations around medical surveillance have been very prominent over the last little while. And I think, Marianne, perhaps I can hand it to you to talk a little bit about, advancing these three pillars, or three pillars is the wrong word, the three streams or three approaches kind of going forward, one being the VR headsets, which Marianne's going to talk a little bit about. So shall I move
Thank
to
you,
here,
Patty.
I suppose?
That'd be great. Thank you. Yeah, so just kind of a little bit more on the history, I guess, for Inuit and perinatal health and resources and that kind of thing for Inuit in the Kivalliq region. So if you're not sure where the Kivalliq region is, it's kind of central Nunavut. Nunavut expands from east to west all across Canada. So it's a large territory, but Kivalliq is just kind of that central region above, I guess, Winnipeg. So that's why so many of the women have to travel to Winnipeg to have their babies, right? That whole kind of evolution around how that came about, in the beginning, Inuit were able to have their babies in community. There might have been traditional midwives. They might have had support from family. Our elders talk about having been born on the land. And that kind of the start of that evolution is still very recent. You know, we still have elders alive today that were born on the land and born with families in community. It wasn't until around the 1950s to say 70s where there was like this huge shift in how women could have their babies. And, you know, like Patty kind of talked about the medicalization of birth, women were required to, in the Kivalliq region, were required to travel to Winnipeg or Churchill to have their babies. And they would have to do that on their own. They didn't have any kind of family with them. Um, they were very they had to do that on their own. Travel on an airplane, head south, have their babies, and have no support. And like Patty said, a lot of them didn't speak English. You know, Inuktitut was their first language. So lots of barriers around knowing what they were consenting to, knowing what was happening to them, and um, lots of fear and anxiety around what that trip must have been like for them on their own without any kind of family support. They would go home with their babies, and that would be the first time that, you know, their partners, their husbands, their family would get to meet or see the baby um, after they had their babies. It wasn't until around 2017, from what I understand, that Inuit women were allowed to bring an escort with them. It could have been their partner, their husband, a family member. Um, they could take with them to Winnipeg to support them when they have their baby. So that tiny bit of improvement, but still, you know, not ideal, especially, you know, if they have other children at home. You know, they have to kind of find other people that might be able to care for those other children. They might not have the financial resources to navigate a city like Winnipeg. Um, their partner might not be able to leave work. There's lots of problems with that situation as well. It's not ideal that they get to go to Winnipeg, have their babies with one person accompanying them. So it's not an ideal situation yet. Um, there was a short period as well probably around the same time, but ended in 2020 where there were some midwives in Rankin and in the Kivalliq region. There were two Inuit midwives, Western trained, who were able to travel kind of within those 7 communities in the Kivalliq region and support women to have their babies. And it was very successful. Inuit women loved having that experience, but it's not sustainable with 2 midwives in the region. They were working 24/7. You know, you can't just have one midwife deliver a baby. You need both midwives there at the same time. Um, you know, highest birth rates in Canada. They were very busy. It wasn't sustainable. And there are talks about trying to have that come back. I know there's work and research happening around trying to make that happen again. It's just that fear around if they can make it sustainable, I think, is the concern. The goal always is, of course, around we want women to be able to have their babies in community with family, and just trying to figure out how to make that happen. So just kind of part of that, you know, with that kind of evolution and that kind of thing, one of the elders kind of talks about, you know, birth is supposed to be a joyful experience, right? She talks about how when she was born on the land, her father was there and he was full of joy. He was so proud and thankful to be a part of that experience, right? And he was there to name her. And, you know, naming children in Inuit communities as a whole other topic, but an important and meaningful way for a family to be a part of that experience and celebrate the birth of that child in the community, right? So I feel, you know, the elders kind of talk about how a lot of that joy has just kind of been stripped from us because we can't have our babies in community with family. So going forward, one of the things that we've been working on is developing these VR immersive technology resources. And it's kind of a melding of, you know, that technology with Inuit knowledge. And like Patty talked, there are a lot of young people that have babies in the Kivalliq region. So we thought this was kind of a good way to encourage them to engage in learning a little bit more, preparing for that trip that they were going to have to make when they go to Winnipeg, right? There's a lot of fear and anxiety around making that trip, especially when you're young. If it's your first baby, not knowing what to expect, not knowing what that might look like. So with the VR immersive technology, we're just trying to hopefully make it a little safer for them when they need to make that trip. The VR immersive technology is going to include a little bit of cultural information, like especially you'll hear from elders' voices, you'll hear from Inuit women and their experience, some kind of land references, and things like that. Lydia's wall hanging that we saw earlier will be incorporated in the VR technology as well. And then it'll incorporate also some of the practical things associated with having to make that trip south. So things like getting a tour from the airport to the boarding home where they have to get on a bus. They enter the boarding home and what that's going to look like. Getting a tour of the boarding home where they're confined until they have their babies. Seeing what that boarding home looks like. Maybe getting a tour of some of the hospitals and seeing what those might look like. And then there'll be some like virtual avatars, some medical professionals kind of sharing information on, say, what a C-section is or what an epidural might be and those kinds of medical things that they may experience when they're in hospital as well. So it's a melding of kind of those cultural components and the practical components and trying to prepare those women when they need to make that trip south. And in November, we had the opportunity to bring a couple people from Nunavut, from the Kivalliq region down to the University of Calgary. We had the software engineers, we had medical professionals, we had some researchers, students, a good number of us there talking about what these VR resources would look like and what we want to incorporate. We had the opportunity to test out what VR resources might look like or feel like, and just kind of start that initial planning around what they would look like. And now we're at the stage where we're working with the software engineers around kind of starting that initial platform, I guess. We decided that we were going to start from a home setting in Nunavut. And when you have the goggles on, you'll be able to move throughout different rooms in the home to watch different videos, to get in on those different tours and kind of learn more from those virtual avatars and that kind of thing. So again, try to make sure it feels like a safe space for people to kind of learn more and participate in what that experience will be like. Is there anything else you think I'm missing, Patty?
I'm going to jump in
Mhm.
and perhaps if there are other additional comments, you can add them in the Q&A. I'm hearing these threads around the social determinants, but also very clearly across about rights violations, right? The violation of the sexual and reproductive rights of women and birthing people. And so I think that I'm expecting there to be interesting information in the next presentation and that we can come back and touch on this in the panel discussion. Thank you very much,
Thanks, Tamil.
Marianne and Patty. So now I'm going to introduce Dr. Saraswati Vedam, Gabrielle Griffith, and Bhavya Reddy, who are going to speak about the Justice and Equity in Perinatal Services Hub, centering marginalized voices in research and solutions. I could go on about them and their work, but I will be brief. So Dr. Saraswati Vedam is the lead investigator of the Birthplace Lab at the University of British Columbia and a health professional investigator with the Michael Smith Health Research Foundation. Over 40 years, her work has set standards for international policy on the place of birth, midwifery integration, and measurement of high-quality perinatal services. Currently, she is leading not only the Birthplace Lab, but this particular hub. And she has developed instruments with her team that have been applied in research and quality improvement programs that measure abuse and mistreatment and other quality measures during childbirth. Gabrielle Griffith is a queer, non-binary, and neurodivergent individual who advocates for inclusivity, holistic well-being, and progressive community-based research in perinatal care. Gabrielle is a birth parent, a full-spectrum doula, community researcher, and educator, promoting anti-oppressive harm reduction and trauma-informed practices to improve perinatal mental health for marginalized communities. And Bhavya Reddy is a public health researcher with over a decade of experience in global perinatal health, with a focus on promoting evidence-based and respectful intrapartum care. She is a PhD candidate at the School of Population and Public Health at UBC, and she is conducting her doctoral research with the Birthplace Lab, examining relationships between mode of birth, intrapartum care experiences, and postpartum PTSD. Welcome to all of you, and I'll hand over the microphone.
Thank you so much, Tamil, and thank you to the co-presenters who preceded us, who have really, I honor the work you're doing. It's so nice for me as a researcher who's been involved in participatory process to see other and meet like-minded people. It's as a midwife and a person who's committed to justice, equity, and kindness, and birth on community. My lab is called the Birthplace Lab because birth and community is what I've been doing and followed for these 40 years. So I'm really so impressed by everything that was presented. And I hope that today we can bring some hope and positivity to where we're going together. So I'm grateful to be joining traditional and unceded homelands of the Musqueam, Tsleil-Waututh, and Squamish nations. I'm especially thankful for the guidance of Elder Roberta Price in the conduct of this work, and acknowledge also my own ancestors who experienced the effects of colonization, oppression, and disrespect in another land. We are going to speak to you today about our hub, which is focused on person-centered measurement of equities, quality, and safety, including anti-racism and the reduction of mistreatment and oppression over the course of pregnancy and childbirth and postpartum. As I'm learning constantly, we have used the word perinatal and reclaimed it from being a high-risk newborn term to talk about the continuum, but I'm interested and hoping to learn more about the Inuit approach to that word and other ways to represent this critical time in families. We are trying to co-design with service users accountability systems for rights-based care, improve health professional and public education on reproductive justice, and to do so, expand representation both in the research and clinical workforce. So that's what we think about as participatory methods in order to monitor the quality of perinatal services, educate healthcare workers, or implement perinatal health improvement tools. We need to understand what's most important to service users. We've codified this process through the lab, and where in our various studies, the community decides what to study. They select and design the measures. They lead recruitment. They decide how to explore the data, how to interpret the findings. They decide on the key messages, how to tell the story, and who needs to hear the results. So that's walking the walk throughout our process is what's taking us to asking different questions and finding different solutions. Our JEPS work follows on the evidence gathered through a national study called RESPECT, that's research examining the stories of pregnancy and childbirth in Canada today. where we were fortunate to build trusting relationships with partners across the country. Chief among those is the National Council of Indigenous Midwives, who are working to expand access to Indigenous models of pregnancy and childbirth care on a national level and through our regional sites. And then we also intentionally seek and could not do the work without our collaborations with non-traditional community partners and knowledge user organizations that serve and listen to the concerns of marginalized communities and populations. I will point out just a few of them. There's the Firelight Research Group, which is an Indigenous-led research group that uses GIS, work to think about all the things that affect Indigenous communities and being on the land and what that means throughout the life cycle. We work with Unlocking the Gates, which is a NGO founded by formerly incarcerated women who learned about research and knowledge translation and now are providing services to those families affected by incarceration. We have partners with the Black Physicians of Canada, with Elfin Circle, which is a human rights law and justice organization. Yeah, and you'll recognize some of the others, I'm sure. I'm going to turn it over now to Gab Griffith, who will tell you a little bit from the perspective of a service user who's been partnering with us.
Thanks, Saras. Hi, everyone. My name is Gabrielle Griffith, they, she pronouns, and I am joining the space as a community member, community researcher. I wanted to share a little bit about my journey. The folks that were presenting earlier really highlighted the importance of engaging community from the beginning, and that has been my experience working with the Birthplace Lab. I got to join as a community steering council member back in 2018 when the Respect study was just beginning, and now we're here into 2025, and I'm still rooted and engaged and excited about the potential that we have here as a team and a group to really make strides and make impact in the community. I have the question there on the slides, why is it important to create opportunities for community members in research? And this is something I've been reflecting on a lot lately because I started in 2018 as a parent, as a community member, eager to share my stories and experiences navigating health and social care, and have grown. My capacity has built, my skill set has built, and had different opportunities along the way to connect with different projects and share my story and be validated in my experience despite not having that academic background. And now I was able to apply to a program that they have at McMaster called the Community Engaged CERE, Community Engaged Evaluation and Research Program, to continue to build my capacity and engage in research in a totally different way that had I not been introduced to the Birthplace Lab from a trusted community member, I don't know if I ever would have looked to engage in research. And so I really love being in spaces like this where we can talk about how do we make this accessible, because while the experience was always open and welcome, there was different tensions that we navigated throughout as I engaged in our group discussions. Do you want to go to the next slide? And so here at the Birthplace Lab, engaging the community through every single stage of the project has been crucial. And a part of the role as the community steering council is choosing the topics of what we talk about. So access to models of birth care, the experiences of pregnancy and birth care, how decision making is navigated, respect and autonomy, racism, mistreatment, consent and declining interventions, health systems and disrespect, essentially what builds health and well-being. And what manuscripts get written, what knowledge translation projects get focused on is all led and rooted by the voices of the community. And I'll speak for myself and Saras and Bhavya if you want to add in. That has been my experience of research, and so it really feels grounded in that active anti-oppressive practice and in centering those with lived experience, and doing so in an ongoing way, meeting folks where they're at, and continuing to make things accessible and be willing to learn and shift and grow, despite what you're used to navigating as a researcher. This slide here is just all of the different incredible people that have been a part of the Respect Project, whether through the Community Steering Council or the Regional Recruitment Coordinator. We couldn't have done this work without everyone. The Steering Council was there to help us build up the project, think about what questions should we be asking, how should things be phrased, what do we need to consider, and the recruitment coordinators helped us spread the word, get folks to sign up for the survey. And unfortunately, this project launched in 2020 at the height of the pandemic. And still, because we were rooted in community from the beginning, we were able to make those connections and shift in real time how we were going to navigate the recruitment process. And so we had to do things all digital. And this is a screenshot of the website that was shared around online. And we wanted to include this here because one of the key messages that came from the community members was the importance of seeing themselves. And so if we're going to share this around on social media and get people to want to participate and share their stories genuinely and honestly, they needed to see themselves in the project.
Thank you, Gab, so much. And Bhavya?
Hi, I'm Bhavya Reddy, and I'm also very fortunate to live and work on the lands of the Musqueam, Squamish, and Tsleil-Waututh nations. And I am a South Asian new immigrant to Canada and come with my own experience of being a colonized person. So I am going to talk a little bit about how I feel this work adds to and the direction it goes in from maybe dominant ways of doing population health research, which I've been exposed to. And if it starts with the philosophical assumptions that begin our thinking around this. And in traditional population health, reality is objective, measurable, generalizable, and those things still matter. But here, lived experience is central, and we don't question the legitimacy of it. We also recognize that people's experiences systematically differ based on their intersectional identity and their experiences within a historical, political, and social context. Without getting too jargony, the sort of post-positivist research that dominates population and public health, that paradigm flows from those philosophical assumptions you see up there, and the but here, as the speakers before us talked as well, the emphasis is built around changing entrenched systems, but it also values pragmatism and focusing on ways that we can change it. Traditional quantitative work in population health, they may draw on theory. There's certainly assumptions about and understandings of causal relationships, say dose-response relationships if you're an epidemiologist, health behavior models, and health systems and policy research frameworks around how processes and outcomes and so on. But here, all of the work it's not rejecting any of that, but it's working from a social justice foundation and principles. And so we often draw on critical theories to do the research. Most often that would mean critical feminist theory, critical race theory, and certainly intersectionality theory. And if you think of, again, an epidemiology lens, or how quantitative research is conducted in the health field, there is a focus on risk and disease, and identifying risk, and then accurately measuring that risk. But here there's a salutogenic approach, what is really producing health rather than risk and disease. And so at the design stage, we build in with communities, and this can really only be done if you're designing it with communities and communities are leading it, that you're identifying assets, that you're building in questions and hypotheses that could potentially address inequities and close gaps. An example of this would be, so some of our work, colleagues at the Birthplace Lab who are leading work on autonomy and decision-making in perinatal care, while they've found differences between marginalized groups, including racial differences, they have also identified areas of care which could include things like longer time in consultations, culture-matched care, and different things in the care context that could actually reduce some of those inequities. And then on to data governance. Typically, once service users provide their information in communities, then they don't often have control over the data. And so here, communities and service users lead all of that, and they play a foundational role. So, Saras, if you could switch to just the next slide for a minute. I as a new person to Canada, was introduced to OCAP principles, which I found incredibly valuable, and everyone at the lab is trained in this, and that's really about OCAP is a tool to support strong information governance on the path to First Nations data sovereignty. And at the hub here, our analysis on SAFE analysis is focused on Indigenous populations. That analysis is led by Indigenous partners. And if we are doing research which ends up highlighting an aspect of Indigenous experience or outcomes, that is still unpacked with Indigenous collaborators. And we also use principles of EGAP that was developed by the Black Health Equity Working Group, and that's focused on uncovering inequities and also holding authorities accountable for improving policy and practice, and ultimately addressing structural racism through community involvement. If you could go back, Saras. Yep. So next slide, please, Saras. So if you think of how communities and service users are typically how they feature in the research process, they may validate a survey tool, and you might see how communities understand questions, and they certainly participate in studies. But here, as Gab mentioned, this all starts with communities. And so they are determining what questions get asked, what priorities they have, what do they want to know, and it starts there. And in terms of design, typically, quantitative research is focusing on reducing bias, measurement error, and getting to as much certainty as you can to know a relationship or know an outcome, and that's certainly remains something we strive for at the lab. But here we're really centering service user experience and being able to reach the most marginalized groups where the work is done in the design stage. And that means asking questions in different ways, which Saras has said. That could be, for instance, we we collect information. People may report their race, but you're also asking them about their experience of racism. So you're measuring both. You're identifying race, also measuring racism. You are getting at experiences in a few different ways, so you can triangulate information at the analysis stage, and it's also important as this field evolves that we are able to compare how things are traditionally measured and how that compares to the way people report their experiences. And we're able to sort of make sense of that through the analysis of research conducted in this way. And as Gab also mentioned, while the analysis is typically held by researchers or academics in traditional research, here we're really working with communities. So in my experience, so I'm as a doctoral student at the lab, I present my evolving proposal with our community steering council, and it's not just feedback. I'm checking if this is relevant. Is this a question that is worth asking? And so they have the power to modify and shape some of the things that I am interested in doing. And at the analysis stage, this would also mean things like, if I find a quantitative relationship, I can go to our community steering council or community partners and talk about why do you think this relationship exists? Is there something more I need to be looking at? And there might be suggestions that come from the community steering council that might inform further modeling. So it's not about everyone having the same skills or expertise, but it's about being able to incorporate different types of knowledge with the methods that we are traditionally trained in. And then with knowledge mobilization, we certainly do manuscripts and attend conferences and all of the traditional methods. But we, as Saras will talk about next, there are a variety of knowledge mobilization products. There's also data is not used at the end of the cycle. It's used cyclically with communities. The findings are prioritized based on community need. And then the messages are pragmatic, they're in lay language. And so they may not follow this linear path of what gets released in what format and who has access to it. It's much more integrated and uses multiple ways, which Saras will talk about more. If there's anything else, Saras, let me know. Otherwise, I'll hand over to you.
Thank you so much, Bhavya. And I know we're coming up on our time, so I'll just quickly show you some of the products that based on what our communities have said are important to us, that manuscripts are not as important as actually doing something pragmatic, and like our colleagues from the Inuit nations, really making pragmatic. What do people need? They need to understand what's going to happen when they're relocated. What do people need? They need to be respected when they enter decision making. So we have a course for interprofessional providers to learn how to keep the person at the center of every decision that's made, and that they are in charge, and they have to first figure out who the decision makers are, name and explain, clarify and check their understanding, allow time for consideration and reflection, and attend to the power imbalances that exist. So we teach people how to do this. We also have a quality measure that can be implemented at the facility level to preserve that sense of being in an undisturbed labor and birth as you can when you're in community or in your own home, where you're not, your body can function without all of those outside stressors. And when we keep those environments safe and have companionship, have the evidence-based practices that are across 18 different domains, if we're accountable to those, then in fact we will have less C-sections and less people who are relocated from the Inuit because now they've had a C-section and now they have a different risk profile because of having a scar. So if we can increase the amount of physiologic birth without without impact on health and well-being, then everybody benefits. And finally, we have a set of, we've taken our research tools, which Bhavya mentioned too, around measurement of autonomy and respect and mistreatment. Things like I was shouted at, I was scolded, healthcare providers threatened me, they delayed their response to my request for help, they ignored me. Those kinds of human rights abuses are reportable and really are health human rights. And so we have developed a safe place for people to report on those and then decide whether they want to share their autonomy, respect, and mistreatment scores to the institution where they, in an anonymous aggregate way, to the institution where they provided care, so that they can go on, check their own level of autonomy, respect, and mistreatment, understand that that was not okay in the context of where their score falls with the national data sets, and then decide whether or not they want to join us in providing accountability. So I'll just close by saying that when we do this intentional research practice, it includes that pragmatic knowledge mobilization, and that's how we have to prioritize change instead of waiting forever. And that, you know, it takes time, certainly, that you have to make sure that you're working always with under the trainees, faculty, community members, community researchers who can help you do things in a different way. You know, there's famous people who said that if you keep trying to make change by doing things the same way, it doesn't happen. So that community capacity building is very important. Asking different questions in different ways is important. And then as you bring these new or ancient pieces of knowledge, as the Indigenous communities have told us that they've known how to provide community elders teachings, surround families with how they can achieve optimal health and well-being throughout their life cycle. If we can open our ears and listen and go forward together, then that's when we will really see that health equity come into our space. So thanks so much.
Thank you very much, Saras, Gabs, and Bhavya. I'd like to welcome all of our panelists back and to encourage our audience members to put questions that they have in the chat. I've been excited. Each of you has really emphasized and together the importance of true engagement and meaningful participation in research and along the research continuum, and have given really impressive, I think, examples of that happening from design through data collection and into analysis and creation of knowledge products, which is really exciting to see these examples. And then pragmatic ways that you're moving this forward in terms of the courses for healthcare providers, the VR to familiarize these other accountability tools. And these hubs are quite early in what we would consider in a research process. So you're really at the beginning of these journeys in some ways with the perinatal hubs. And so I wanted to ask each of the hub leads and their co-presenters if they would share some with the audience about what's your aspiration, your pragmatic aspiration of or expectations in terms of the guidance and system transformation that we might see out of the individual and collective work of these hubs when they come to an end. And if you have thoughts about how those listening and other networks can turbocharge that for you or help you reach those aspirational goals, I'm sure we'd love to hear that as well.
I'll start by saying that I hope that all of these initiatives and insights that the community members have brought to all of our hubs can turn into these pragmatic tools like what Marian Forbes described that actually become business as usual, not just a pilot project, not just a funded research thing, but as fundamental as the hand washing courses that we all have to take, that everybody is required as a provider to do. That, whether it's learning about doing the sannyas course, doing the cultural safety things, understanding person-centered decision making, and also that systems are all health systems across the board are required to be accountable to their service users. That those reporting becomes so usual that we don't have to take it to an outside hub like we have to create safety. That it becomes business, that people get to give feedback in a way that doesn't affect their care. Because right now we feel like we can't do it through the hospital system because there's such a break in trust. And as someone early on said, if the trust is broken, the uptake of care won't be there. So why would they report? Why would they report through the system? So I would like to see, that would be my vision for the future.
Please go ahead, Isabel.
Well, just to sort of bounce off what Sarah's just mentioned, our hub really addresses an area that has traditionally been very much influenced by the biomedical model of care. Many individuals who experience serious adverse events, near miss events, are taken care of in a hospital setting. And so in order to make come to reality this idea that equitable and safe care should be available to anyone, whether they're being, looked after in a hospital setting or outside of the hospital setting, and in any model of care, there should be respectful care and the standards should be upheld. And so I think in our hub, we're looking to develop tools that are going to be inspired from learnings from other models of care and other philosophies surrounding care to bring them into the hospital. When people who do need hospital care are, looked after in a hospital. And that includes the tangible tools and processes to improve care, but in a way that centers on people and persons and their lived experience of the care, and that so that care is done with them and not to them in that way in the hospital.
Yes, I can chime in. I think what would be ideal is for everything that we've all spoken about to come to fruition. So we're not working in silos, because today we've all talked about safe, equitable care, anti-oppression, respect, safe space. I mean, it's not something that should be difficult. It should be part of human right. Okay, so reproductive rights, reproductive justice, I'm hoping that at the end of it all, wherever our patients turn to, which could even be us, we would trust the system, that the system will actually take care of us and take care of us very, very well. And I also envisage that working with the community, it's so important. Listening to people, their lived experience. Even as a physician or other healthcare providers, I think we learn from what we've been told, because that kind of shapes the way we move on. And it's an ongoing learning process. So whichever tools, wherever we end, I'm hoping that this will reduce the mortality, the morbidity, and it would also make our healthcare safe. Thank you.
I'd like to jump in. I feel like it's pragmatic, but maybe it's wishful thinking. I just loved hearing everyone share and to follow up on what Modupe was sharing. I would love to see more collaboration. I think about my own experience in research. It wouldn't exist without collaboration. It wouldn't have existed without the emphasis and validation of the lived experience as knowledge, and honoring that and centering that. And so I'd love more opportunities for folks outside of this space and within this space to be adequately resourced and funded so that they can take the time, move at the pace of trust, bring in folks into the community and not have to rush through things in like 2 or 3 community engagement sessions, but really do things intentionally and slowly. And that's what I wanted to bring into the space.
Thank you very much. Patty and Marianne, do you have thoughts to add?
I do. Marianne, did you want to go first? No. Okay. One thing that comes to mind, and I can't echo, enough what everyone else has just said. I agree with it all entirely. We have a number of physicians as part of our hub, and one of the conversations that we've had a number of times is like the value that they find of being in the meetings and listening to the women's voices, and where they had a certain level of awareness of some of these issues, they hadn't really had quite the level of kind of nuanced understanding that they have currently now as part of this work, which I think strikes such an important chord. When we were talking about, creating the VR headsets, a big conversation that we've had is, how do we bring, care has to be, perinatal care is collective care. It has to be collective. It has to be, coming from community, and that includes physicians, it includes fathers, it includes, all the people that support the person who is having a child, but also then post-child and pre-child and all of those experiences, along that continuum. And so we've been recently, trying to figure out how to, engage men, partners, fathers within this work as well as elders more intimately. But also, how do we start to think about linking to offer information that would be desired by healthcare workers, those, and social services workers, those people who are in the hospitals and really accessing this. And so thinking about who our audience is really always a big part of this work. And we're aware that, there's only so much space within, medical, nursing, social work, kind of education programs. But one thing we've been talking a little bit about, and I'm sure Marianne, maybe you want to speak to this too, is that, how do we also bring Inuit voice to the forefront within what we're doing, so that some of those workers who, and this is, we know that there's a lot of racism and discrimination, but we also know that there's a lot of workers who are really, we want to give the most generous kind of, understanding to these, are trying their best, but don't have a sense of that, what internally individuals might be feeling in those encounters. And so, some of those conversations are, how do we create space for them to hear that within what we're doing too? And that's a vast challenge, but it's a really important one, because the influence isn't just, at the training and the policy level. It's also in the, like, you've been working in the field for 22 years, and this is something that you've only got this level of awareness of, and we want to perhaps even challenge some of the belief systems and the ideas that may have been implanted over those 22 years, so that the interactions going forward could be, really based on, in a place of connection and positive engagement. And until we get to a place where, as Marianne was saying, birthing can happen in communities, by Inuit with Inuit, so that love and that cultural kind of awareness is there, until we're at that point, what do we do in this meantime, to ensure that the woman tomorrow who goes in for care is treated with I'd say love, but the love, the respect, the dignity that every person deserves. Thank you, Timo.
I just wanted to say, I think, and I heard a little bit today too about some of the things that are happening, which is really cool. But I think one of the things that we are still really struggling to is just around reproductive rights and how women can advocate for themselves or recognize when people might be asking certain questions for certain reasons, right? That might put them at risk. So I think that's a big struggle that we're having in terms of, wanting to share information with women so that they are prepared if they're confronted with anything, and knowing how to respond to those situations. And doing that in a way that doesn't scare them more, right? Yeah, I think that's just one of our struggles that's kind of heavy on our hearts, and kind of figuring out how to navigate that with community, because the elders want to make sure that we're focusing on the joy, but we also need to find out how to protect women when they're making those trips south as well. So, because that's a big concern for them once they're there. They might not know it's coming, but they might be hit with it once they're there, and not know how to navigate those situations. So,
Marianne, we'd be happy to collaborate with you and connect you with our partners at Evelyn Circle, who have created some wonderful tools for everybody. Because when we study this across Canada, it's 22%. While it's true that Indigenous and Black people experience more mistreatment, it is a 22% of the Canadian population. When we have over 6,000 responses, are experiencing some. So everybody needs to learn how to
yeah,
advocate that for themselves and do it with, with a smile
right.
and yeah, I think that's the whole point of this hub, so we should be talking to each other about what, each of us have our things that we really focus on. And I think if we cross fertilize, it's possible.
That would be great. Thank you. Mhm.
And I think that it's kind of tragic to say, but in the area of sexual and reproductive rights, particularly for groups who are discriminated against, right, in this society that we live in, many times those abuses, those human rights violations are highly normalized. And so the stigma creates that. And in my own experience in the past, working with women living with HIV, the conversation within the community and actually coming to internalize the idea that these are my rights and that abuse is not normal, can happen in that peer and with that elder setting. So it's kind of about we thought partially about repetition and support from the community, and then there becomes a transformation for people. So you might not get to a transformation before people travel south, but as part of preparation, and especially I think if there's support from elders around defending those rights, from community leaders around defending those rights, I think that it starts to make a cultural shift, which can protect people.
I just want to add that when I compare what we see in the RESPECT study that covered all provinces and territories here, and working on these same issues in the global south, this issue of violence and abuse being normalized is certainly true here. But one of the encouraging things I've seen through people's narratives in this study is they do have a pretty strong sense of their rights. And it may not be like knowing how to operationalize them, but the reactions you hear from people who have had these encounters is that anger is good. It's encouraging. It means that they have a sense of their rights. And I've worked in contexts where it's so silenced and so normalized, it's not even being processed. And this is demonstrated in global research where observations of labor and birth and people's report were very different. The observations yielded much higher reports. So I think there's something here that can actually be capitalized on more. And I'm actually very encouraged by hearing people's frustration and anger and their ability to articulate what exactly went wrong and why they were violated.
I want to just respond to the elders' advice and also our Indigenous partners around joy and focusing on health and well-being. I think that when people have self-agency, they are able to move towards joy. And I think that's one way we can speak to the elders about that. And also when they can birth on their own, when it's not a C-section, when they can birth upright, when they can hold their babies right away, a lot of that is very healing, even when they're far away from their community. So I think to get also the support of the elders for bringing birth back to that physiologic process as a priority for, especially for young women, and that will bring them joy and confidence as parents as well.
Please, thank you so much for those reflections. And Isabel, please go ahead.
Maybe I'm just inviting, you know, to a reflection also surrounding the theme of joy and making space for all the experiences that are surrounding pregnancy and not just childbirth. In the area of pregnancy and post-pregnancy care, it also encompasses, you know, pregnancy losses, it encompasses miscarriages, it encompasses a certain degree of grieving, it encompasses a certain degree of disappointment sometimes, and making space for the diversity of experiences in pregnancy is profoundly anti-oppressive, and letting people experience the whole range and the whole spectrum. And that has been something that I have found really helpful as a person with lived expertise of caring for others in the hospital setting and my own pregnancies, just leaving that space. And I think encouraging individuals to get in touch with their own lived expertise and just making room for all of it. That's just a reflection I wanted to share.
Thank you, Isabel. Modupe.
I don't want to take too much time, but I just want to reflect on the ability to have culturally appropriate healthcare providers. And as you know, we are not looking into that, like doulas, you know, midwives, you know, I don't know how many, there are very few Black doulas, Black midwives, even the doulas, you know, they're not cheap for an average Black woman to be able to access that. So these inequities are quite, you know, profound in some communities. And the fact that, you know, we are able to talk about them is to ensure that whatever policy or QI projects we put out there, we follow it to completion to the point of accountability. Otherwise, you know, we keep saying this, we talk all the time, but nothing, the needle doesn't really move. How do we move the conversation to those people who really matters, okay? You know, next week is still going to be the same set of people. Where are the people who actually control the dollars and move the policy? So I think, you know, as much as we do this, how do we even get those people involved? They may not be the same gender as us, but they need to be part of that conversation so that we can all work collectively to change the status quo.
Thanks to all of you for your deep reflections and sharing this knowledge, and for the transformational work. We've heard that it takes transformation across, from the way that we do research actually to our healthcare structures and our hospitals and their quality improvement systems, and all the way up to policy and the financing and the for healthcare services. So I thank all of you and the hubs for being seeds in this, and for sharing your knowledge. And I want to thank all of you for attending, the audience for attending and for asking questions. There's an invitation in the chat for those who have expertise in this area to consider becoming part of a sexual and reproductive health standards organization working group, and also the question about whether the video of this will be made available. Of course, it will be available in its entirety on the POWER website. So please do go back and consult it. And I want to wish all of you also a wonderful International Women's History Month, and on the 8th, a wonderful International Women's Day. So thanks very much.
Thank you for having us, Tamil. This was wonderful.
Thank you. We'll be in touch.
Thank you.